especially during the corona period for the last 2 or 3 years, it has become very important and widely used. What are the indications of lung ultrasound? You can see here asthma, accuracy more than 90%, chronic obstructive pulmonary disease, pneumonia, pneumothorax, pulmonary edema, and pulmonary embolism. Accuracy more than 90%. And you can see here all the emergencies related to lungs that can be managed, that can be diagnosed by using lung ultrasound. And nowadays, you can see there is another group of people and another extension of routine ultrasound group, that is point of care ultrasound. We are nowadays we are seeing it in many forums, in many journals, everywhere, also training program also. In short, it is called POCUS. Then what is POCUS? POCUS is targeted ultrasound intervention. Short duration, targeted to see something, not a general intervention, targeted intervention. And done at bedside and in emergency mainly. And mainly performed by the clinicians as an extension of a stethoscope. As if the clinician is using a stethoscope, just like that. That doesn't mean that we do not need some special person, just like ultrasound specialist or radiologist. Not that. We also need them. But clearly, patient management at the bedside, especially emergency situation, the clinician, they used to use this POCUS system, point of care ultrasound. So lung ultrasound is also a part of this POCUS machine. Ultrasound machines have become smaller, very small size, with a small size machine, but with all the facilities nowadays, because there are huge development of computer technology, software technology. So within very short space, everything, we can get everything. And these handheld ultrasound are ideal in this situation with their small size, portability, ability to produce high quality image, and easy to decontamination. Just like this. You can see this is butterfly IQ portable ultrasound. They are very small size. Only this probe. We can attach this probe with our mobile phone or tab. Of course, there are some advanced quality, and we can do the ultrasound. This is very suitable. In the routine practice, we should use the transducer just like curvilinear 2 to 5 megahertz linear. We will use linear. That is also needed, 7.5 to 10 megahertz. And also turn off. We use the high quality machine with so many facilities and so many advanced technology. But when we are going to use the lungs, we should make it off all the high quality technologies like tissue harmonic, no use of tissue harmonic or temporal aberration, compounding or speckle reduction. Why we should make this off? I shall explain it. Actually, all these things probably you know, but all it needs very wide discussion, physics discussion. That is not within the scope of this lecture. And this is the patient position. We shall examine from the front side and from the side, lateral side, mainly in the supine when the patient is in supine normal position. But if we need the back side, in that case, usually we ask the patient to sit so that from back side or stand, we can examine the other side also. You can see here the different position and techniques. And now I would like to say a few words about the lung pathology. You can see this one is normal. Alveolar, normal alveolar. Now all the air sacs, they are full of air. This is normal. Ultrasound of lung, this is normal. The second one, that is interstitial syndrome. That means the interstitial space that containing fluid. Rather, I should say some liquid. That's the congestion, lung congestion. And the sac, they are half filled or partly filled. So there is some fluid inside the air sac. This is interstitial syndrome and ultimately consolidation. Consolidate alveoli. That is the full of other material, other liquid or some solid material. It becomes solid, consolidated. That is hepatization of lungs. So all this is a sequence. This is the sequence. And here you can see this is normal, then congestion, then consolidation, and ultimately fluid in the pleural space. And when the patient improves, and during the resolution time, just reverse from the fluid, then consolidation, then congestion, and then normal. This is the sequence. And now, this is very small physics. What is the limitation of the ultrasound? Ultrasound cannot penetrate bones and casts. That is the basic. For that reason, we can examine the adult brain. In some cases, especially in neonatal period, when the anterior and posterior frontal lobe through the temporal bone, we can see the brain. At that time, that thin bones or some membrane, through that ultrasound can pass inside and we can see the brain. But we can examine the adult. Why? Because the skull, the ultrasound can penetrate bones. That is number one. And gas, it can penetrate the gas. That means we can't examine the lungs because lung is full of gas. We can see that. And we cannot examine the intestine. Intestine contains gaseous substance. For that reason, adult brain, lungs, and intestine. So here you are seeing there is a contradiction. I am telling we are going to examine the lungs, and again I am telling that we cannot examine the lungs, as because there is here. What is the fallacy? Here you can see the upper part, that is the real image. The lower part, that is reflection, that is not the real image, that is artifact. We can see, we can touch it. But upper part, that is real image. This is lower part. And here you can see this baby. Here is the reflection. This is real, this is artifact. But here you can see this is undisturbed water. The fissure is quite okay. But when the water is disturbed, the image is also disturbed. By seeing this image, this is not real, but by seeing this image, artifact, we can say that the media there is some turbulence. So in fact, during lung examination, we are not seeing the real image. Actually, we are examining all the artifacts. By seeing the artifacts, we can say whether this is normal or this is abnormal. Just like In gall, when we are going to examine the gall stone, there are some shadow, but shadow is not real. That is an artifact. There is no such thing inside the body, just like this black area. That's the artifact. But this artifact, by seeing the artifact, we can diagnose this is the gallstone. By seeing this image quality, this is disturbed image, we can say this water is disturbed. So actually, during lung examination, we are actually seeing the artifacts, some artifacts. Here is the image, just like this is the normal lung. But here is the skin is seen like that. We can see skin very nicely. Then subcutaneous tissue, vesicogenic zone. Then muscle, vesicogenic zone. You can see it here. Muscle. And this is the bones. Bones. These two bones. Rib. And this is pleural line. Plural. In the plural line, there is a interface, and inside lungs this is airflow. So we can't see the lungs. But at the level of the interface, it is producing some artifacts, reverberation artifacts. All this line, all this parallel line, this is reverberation artifact. So when we are seeing this reverberation artifact, some parallel line, then we can say this lung is okay. This is okay. By seeing the artifact, we can say the lung is okay. This is normal. So all this parallel line, this is called A line. For diagnostic purpose, this is A line. When there is A line, that means the lung is normal. A line. You can see so many A line. So this is normal. And also, if we use the power Doppler, we can just start the power Doppler, and at that level, the lung at the interface, at the pleural line, the lung is going up, down. So there is some motion. So when we use the power Doppler, then there are power slide signs. You can see all this color. When we get this color, that means it is normal. And also here, if we use the M mode, we know we use the M mode during our heart examination. We are using the M mode. And at this level, that is pleural line. Pleural line, that is also lungs is going up and down, there is a motion. And this M mode, that is giving some special type of image like that. It is also scrolling from this side to that side, scrolling. This image. And this is called seashore sign. This is just like seashore sign. If we get seashore sign, then it is normal. The lung is normal. But here you can see when there is congestion, the ultrasound beam, ultrasound nerve can pass to some extent, and they are giving this some special. This is some sort of comet tail artifact or ring down artifact. That indicates this is the case of congestion. This is comet tail artifact or ring down artifact. When you get this comet tail, more comet tail artifact, more congestion. 1 or 2, less, mild. And ultimately, congestion, then it becomes solid, and liver or tissue like in the earliest stage, that is called hepatization. This is not congestion, but actually this is, it becomes solid. This is called C profile. And of course, there may be collection of fluid. In our routine examination, when we are going to examine our liver, many times we are seeing that above the diaphragm there are collection of fluid. So there is a pathology in the lungs. We are actually doing that. So collection, pleural fluid collection, that is D profile. Fluid, this D is from fluid, D profile. So there are 4 types of picture. A line, B line, C profile, D profile. Now, how we use this in case of COVID-19? This is COVID, all of us know this. This is some sort of virus. In December 2019, a novel coronavirus named SARS-CoV-2 caused series of acute atypical respiratory disease. It is creating some sort of pneumonia. The virus is transmittable, and we know what a serious condition throughout the whole world for 2 to 3 years. This is COVID-19. And for COVID-19, we use different type of imaging modality, just like X-ray, CT, ultrasound, MRI, and PET-CT. That means we use all type of imaging modality. And for COVID-19, chest X-ray and CT scanning, that is the primary modality. We should use that. But we shall use the ultrasound in some special cases, just like in pregnant women. We cannot use X-ray in pregnant women. We should avoid in pregnant children, and also patients with mechanical ventilation, and where the CT is not available. Many places the CT is not available. But ultrasound, nowadays in Bangladesh, you can use ultrasound in a very remote area, very small bazaar. Also there is a ultrasound machine. That is the development of last 15 or 20 years. And in fact, Bangladesh Society of Ultrasonography has played a very vital role for dissemination of this ultrasound throughout the whole country. And you can see this is the COVID-19. There are ultrasound features. Here is a B line, multiple B line. That is number 1. And also, this is the pleural line. The pleural line is breaking. Here it is not continuous, it is breaking. And also you can see some small breaking, also a small solid part. And also restricted motion. There is no motion.
Motion restricted.
And sometimes there are consolidation. And here it is a bit enlarged with linear 7 to 10 megahertz. You can see this breaking of the pleural line, also a small solid part. So all these are diagnoses of COVID-19. And what are the features? Thickening of the pleural line with pleural irregularity, fragmented pleural and hypocrite areas. B lines in the variety of patterns, including focal, multifocal, and confluent. Consolidations in a variety of patterns, including multifocal, small, non-transglobal, and transglobal, with occasional mobile air bronchograms, appearance of A lines during recovery phase, and of course, pleural effusions are uncommon. All these are features of COVID-19. Here you can see how useful this ultrasound is. This is a 48-year-old female nurse was admitted with complaints of cough and high fever for 2 days. Lung ultrasound showed multiple B lines, whereas chest CT showed ground glass opacities in both lungs. Ground glass opacity is not the feature of COVID-19. So, by using CT, diagnosis is not done. But when we use the same patient, the ultrasound can diagnose. So, this special case, the ultrasound is more sensitive than CT in case of diagnosis of COVID-19. There are so many papers on this comparison between lung ultrasound and compound tomographic findings in patients with COVID-19 pneumonia. Lung ultrasound can detect lung injury even in the presence of normal CT results. There are associations between the abnormalities detected by both methods, and a relationship also exists between lung ultrasound, aeration scores, and the disease extent of CT. And another paper here, lung ultrasound in COVID-19 role beyond acute phase, not only in acute phase, in recovery phase or after. You see, nowadays, probably many of you, especially the senior citizens, they are also suffering from post-COVID syndrome. Many of them. There are so many things. So in those cases, the CT is not in use. Only ultrasound give some guideline. Take home message. Self-protection is top priority. Handheld high-end instrument is suitable. Set the system before starting examination. So everything should be ready before going to the patient, to making the examination short. Set the system before starting examination and try to limit the scanning time. Think about typical findings, just like B lines, pleural irregularities and thickening, consolidation, and multi-lobar distribution of the abnormalities. Thank you.